Hello and welcome everyone for tonight's EAO Just Ask. Tonight, it's an amazing pleasure for me because I have one of my wish candidates tonight with me, and I'm very happy to introduce to you Professor Stefan Wolfart. And we have a great topic tonight. I already tell you we have a great topic tonight because I already had a glimpse into his content and it is just amazing. I already learned a lot in our discussions beforehand. Professor Stefan Wolfart, he is a top-notch expert you've seen on every EAO annual congress. He's the chairman of the Prosto department of the University of Aachen, Germany. If there is a pink Bible, Stefan, I think you wrote the green Bible. You wrote a very famous book everyone should have from the quintessence. It's called Implant Prosthodontics. You are a top speaker all around the world for implant prosthodontics. And you're one of my friends. And this is the most important thing. Stefan, a warm welcome on behalf of the EAO. And thank you for accepting our invitation for tonight's EAO Just Ask.
Stefan, thank you very much for inviting me. It's such a pleasure for me to be in this session with Just Ask. And it's a great pleasure that you invited me, and especially to this topic, which is now one of my favorite topics since 1 week, since I knew that I have to talk about this.
Wow, that sounds amazing. I also look forward to it. We have already a lot of people logging in, everyone for you from Saudi Arabia, from Norway, from Moldavia, from Spain, from Sweden. So all around the world. Hello, everyone. If you have a question, type in your question. I will hand it over to Stefan. And Stefan, I'm a little anxious tonight because I knew I'm going to have you, a top-notch prosthodontist, and me, a very, very small periodontist who does a little bit his prosto him own self. And let me show you a quick case which I finalized today. And I really don't know what you're going to say. So it's 2 implants. I did my impression and I did my final reconstruction today. It's a screw retained reconstruction. I splinted these 2 implants with each other. So Stefan, what do you say? Thumb up, thumb in the middle, or thumb down?
First of all, I have 2 questions to you. One is, do you have implants with a normal length? And second is, do you have a lot of vertical bone augmentation around these implants?
Yes, implant with a normal length and no major bone augmentation performed.
Okay, Stefan. Also, if you're a good friend of mine, I would never have splinted these 2 crowns. I'm sorry for that.
Wow, this is interesting. This sounds like I'm going to learn something. So you want to tell me why, or should I wait for your lecture?
I think you should wait for the lecture, and after the lecture, it would be very interesting to show you the case again, and then you can decide if the next time you will splint it again or not. So that would be very interesting.
Let's do it like this. You show us your content, and after your content, I'm going to tell you if you've brainwashed me and if I changed my ideas. And as it is a little bit the tradition of this Just Ask, you don't mind if I just have a question in between? You saw now, I need to learn a lot. I maybe hand a question over to you in between the lecture. It's not unpolite, but it's just, I think, a nice thing in between. So Stefan, we're all looking forward to your lecture, please.
Okay. Stefan, I'm very happy if you ask me something between, then I can go to this special questions. So first of all, I have made an outline of this talk. And the first thing we want to talk is what for reasons we have to splint or for non-splinting. Because for both, there are good arguments. So first of all, if we have a lot of vertical bone lost, then this is always combined with long implant restorations and a high crown-to-implant ratio. That is important, as you can see here on this side. Long implants and long crowns and short implants. Yeah. So this is one of the important things when we talk about vertical bone problems. So next thing is, if we if we ask ourselves, what is with the chewing force which is coming onto the crown? And there we have a lot of finite element analysis which show us that if we splint crowns, that reduce the stress in the bone. So it's on this side, from this side, it's nice to splint crowns. However, if the crown height is getting higher and higher, then also the stress in the bone and the implant components is stronger, is getting stronger. That means if we have to summarize this, if we have a long crown and we have the forces on the crown, then we'll have more stress on the implant-abutment connection and on the implant itself. Yeah, and if we splint it, we can reduce that. This is the result from these two studies. Next thing is, and this is something we have to think about, it's only a theory, but an important theory. So if you think about the bone, if you put mechanical force in the bone to the bone, then we will get a denser trabecular structure. That means the bone is getting more and more dense. And osseointegration is not a stable situation, it's a dynamic process. That means if we have more force in the bone, maybe it may stabilize the osseointegration in the end. And that, Stefan, is one argument for non-splinting crowns. On the other hand, if we see it from a mechanical point of view, then splinting may protect the implant and implant-abutment connection from external forces. So that means, okay, from a typical mechanical point of view, splinting is a nice thing.
So Stefan, is that what you mean? Is that maybe I also, by my splinting, I reduce the physiologic stress on the bone?
Yes, we do. We do. We have a completely different situation of forces which are going on the bone. If this is more osseointegration or not, that's only a theory. But one theory is more stress on the bone, better trabecular structure, and in the end, a better osseointegration.
That's difficult to judge, probably. How much stress is enough, right? Shouldn't be too much.
Yeah, that's true. Perhaps sometimes you have too much stress, then perhaps you lose an implant. But we know from studies, you lose only implants if you have a peri-implantitis at the same time. If you have a lot of power on the implant and you have a peri-implantitis, then you have the possibility is high that you lose an implant. If you have a stable implant also integrated and you have a lot of force on the implant, you will not lose the implant. So, but it's only a theory which we should keep in mind when we talk about this topic. So this was theory. But if we go to clinical literature, and this is the important point for us as clinicians, then the thing is a little bit different. The EAO consensus statement from 2018, it showed that a crown-to-implant ratio for single tooth restorations between 0.9 to 2.2, that means that the implant is, the crown is as long as the implant, and 2.2 means the crown is double the length of the implant. Yeah? And this with a single crown is not expecting to increase the failure rate and may be considered a good treatment option. So that means we don't have to splint a single crown if we have a crown-to-implant ratio between 0.9 to 2.2. Yeah? And this is also the case when we use short implants from 6 to 8 millimeters. So this statement is completely against splinting crowns in my eyes. So, but on the other hand, we have a very nice meta-analysis, and it's from 2025, so it's really from this year. And it included 17 studies, and we have 1,200 splinted crowns against 800 non-splinted crowns. And the conclusions is that splinting was not found to affect the incidence of biological complications. So if you splint, you have not more biological complications. However, more mechanical complications occurred with non-splinted crowns. That means in the end, if you put both things together, if you splint the crowns, you have less mechanical problems, and splinting is not doing any biological problems. So this statement, in my eyes, is more in the way that splinting is a good idea.
And this statement is in the favor of me.
Yeah, Stefan, I put it in for you. So, and this is also a very interesting study, even if it's a retrospective study, but it's very nice. We have 3 groups in the study: 3 unsplinted crowns, a bridge on 2 implants, and 3 splinted crowns. And the result is the best thing is the bridge, with survival rates 100%, peri-implantitis nearly nothing, and prosthetic complications 13%. If we go for splinted crowns, the prosthetic complications are also only 15%. And if you have non-splinted crowns, and that's also again for you, Stefan, for your theory, the prosthodontic complications, the mechanical complications is 30%, so much higher. However, on the other side, the unsplinted crowns have a better survival rate, and the peri-implantitis is only 7%. And the splinted crown has a survival rate of 88, so it's nearly the same, I think, but peri-implantitis is much higher with 16%. So why is it higher? Perhaps it has, but only a theory of mine, perhaps it has to do with cleaning. So the important thing, if you splint crowns, then that you have interdental spaces which are big enough for interdental brushes. Yeah, and I like it very much if after the last implant you have a pontic area again, and so you have another interdental space where you can go in with a brush, and this brush will really brush the area for the implant. Yeah, and this distal brush is normally very difficult to position. And with such a pontic here, it's very easy for the patient to bring it in.
Stefan, I love that because it gives the patient a guide for the interdental brush.
That's it.
But then you need to splint the crowns.
Yes, I think splinting. I never have told you that every type of splinting is bad.
I got it.
But you're not right. You can do this also as a crown by itself. Okay. Here you have the implant crown and you have one pontic. No problem about this. You can make one implant crown and one pontic. That's not a problem. So this would work also.
Even if you would have an adjacent implant, you would consider that?
In this special, let's talk about this later. Yeah.
Okay, got it.
Let's talk about it later. It has too many components. So now, this is the important thing. Now we come to my concept, and this is a concept which I designed specially for my book, for this green book, which you told us already about. And in the book always need ideas and structure. And so the structure for splinting or non-splinting was, for me, I use splinting if I have a crown implant ratio more than 2. That's the ERO statement. If I have a highly augmented bone area, that's for sinus augmentation. If the whole sinus is full of bioos and I put an implant in, I like it more that it's splinted. If I have very short implants or narrow implants, and if I have an external implant-abutment connection. This is not the case we don't have so many anymore. But on the other hand, there are people who have this Brannemark connection, for example. And if you have such a connection, that means that all the force, all the chewing force is going on the screw. It's not going on the implant-abutment connection. And the difference is if you have an internal implant-abutment connection, then you have a very tight situation here. It's good against bacterial, which could not go into the implant and out of the implant. And on the other hand, you have not so much trouble with the screws. So this is a good thing, and therefore I don't want to, or I don't need splinting for the internal connection, and I should splint with the external connection. So this is the concept, and now we go into the technical realization of these concepts. And so we start with, I show you now 6 cases with completely different situations. So, and I put in these cases my structure, my recommendation, which I showed you. So if you want to go for occlusal screw-retained non-splinted all ceramic crowns, this is the case here in this case where we have low vertical bone loss. We have only sufficient normal bone, no augmentation, and we have a crown implant ratio between 0.8 to 1.3. So that means everything is fine, and there's no reason at all to splint these crowns. And now the big advantage, if we are not splinting these crowns, is that we have the whole internal connection which we can use between implant and crown. So for me, this is a perfect situation.
Stefan, I have a question, and it's a great place. How difficult do you find it in these situations to fit in these crowns? Because some of the implants, they have a very, very long internal connection. I think about the Camlock system, they have a very, very long tube. And I sometimes feel it difficult to get in these single crowns, each by each, without sort of sculpturing on the inter-implant contact.
Okay, the point which you made is a very good point. If you have a lot of failures or misfit, that means your impression was not very good. The cast is not perfect, and then the crowns which are bonded is not perfect. Then you get misfit, and misfit means that the proximal areas will not fit fine. Yeah, and you have problems when you put in the crowns. The good thing is, if you have these problems with single crowns, you can adjust it. Yeah, it took you a long time, that's true. So you should try to avoid these misfits. Mm-hmm. But on the other hand, if you block these crowns, then you have no chance to find this error.
And it's masked.
You block the crown and you screw it in, and you have no ideas where you screw it, and you have no ideas how many pressure you get between between the two implants, because your misfit is there. Yeah?
It's masked. You don't get it.
It's masked. That's the point. So if you can, the only thing where you can really change it is when you cement the crowns. But this we will talk about later.
Okay, got it.
Okay. So next case. Here we have really a marked vertical bone loss, yeah? And we have a sinus augmentation where we have a lot of bio-os here in this area, yeah? And the normal bone is only between 4 to 6 millimeters. And the crown-to-implant ratio is between 0.9 to 1.3, so in a fine area. In this case, we want to have zirconia crowns, which are bonded to T-bases. Though, in this case, because of the situation with a lot of bio-os in this area, I came to the solution to splint these crowns, yeah, for better mechanical stability. But I splint only the posterior 2 crowns, because this crown, when I go back, you see this crown is completely in a normal bone situation, and there for me is no reason to splint this crown. So I splint these 2 crowns because of the sinus augmentation. I'm not splinting this crown. So, and now you see the difference. In this non-splinted crown, I have a very long and parallel bonding area. So the bonding between the ceramic and the T-base will be very good. And here you see we have the whole internal connection is used. For the splinted crowns, we have these conical abutments with a height which is not very good. These T-bases are not used anymore in the moment, but it's always a problem that the industry want to have a conical situation because you try to bond the restorations on the cask, and therefore you have to be sure that implant angulation is not a topic here. And on the other hand, you have this short and conical bonding area, and you have an internal connection which is not fully used. And these are two disadvantages in my eyes in this situation. However, in my eyes, it's in this situation, the advantage of splinting is more important than the disadvantage of non-splinting here. Here you see the crowns, you see the internal connection used. Here it is not used, and you see the restoration in the mouth of the patient. So, third situation. If you want to use if you want to screw and want to use the internal connection, then you have one possibility, and this possibility is multi-unit abutments, because multi-unit abutments are using the whole internal connection. Yeah. On the other hand, you have this multi-unit part here, and in this case, we have a CAD/CAM PFM crown with which are splinted. Why are they splinted? Because again, we have lost a lot of vertical bone, and we have a crown implant ratio between 1.3 to 1.5, relatively high, in combination with a lot of bone augmentation here in the sinus area. So that was the reason for splinting these three crowns. And here you can see that we have the full internal connection. We have a good screw which is holding this in place. However, the problem with these restorations is the prosthodontic screw, because the prosthodontic screw is very small and you could not bring enough load onto this screw, and therefore you have often screw loosening in the situation. Yeah. So the advantage of the multi-unit is you have the internal connection is used. The second disadvantage is you have two gaps, one between bone level and abutment, and then a second between the crowns and the multi-unit abutment. And we have this prosthodontic screw, which is where you could not take too much load on it.
Stefan, great case. I mean, that is also a good one, thinking about a multi-unit abutment construction. If you talk about engaging the complete internal connection, are you thinking of mechanical aspects, or are you also thinking about smaller the gap on bone level? This is also a discussion people guide, because in particular, if you place implants quite deep, it might also make a difference on bone level, on biologic parameters, if you engage the internal connection.
Okay, in the moment I'm speaking more about mechanical points, yeah, because if you start to put in here the biological point, then I think you should, when you really want to be consequent, then you need to use tissue level implants, yeah, because with the tissue level implants you bring your gap out of the tissue, it's not near anymore to the bone, and so I think it's a better solution in this case.
So bad for me, because this was my argument here for splinting my crowns, because I used a hybrid abutment design. You took away my argument again. Sorry.
Okay. I'm so sorry for you tonight, but I don't want, when I want to think biological about these gaps, perhaps then we have to change the situation. Then I would be the moderator and you should be the man on the.
Okay, we'll bring that up to the board. We'll bring that up to the board.
Okay. So the next step is if the position of the implant is a little bit in the wrong way. Yeah. Then the question is, should we go? Can we make occlusal screw retention possible? And it's possible if you go for angled screw connection. That means you can have an angle between up to 25 degrees between the screw and the screwdriver. For that, it's clear you need special screwdrivers with rounded heads and special retaining screws. But if you have this equipment, then you can use the completely internal connection of the abutment, and you can position the screw channel in an optimal position concerning the crown. And the disadvantage with this angled screw connection is only that you can see it here, that the T-base is laterally reduced. Yeah, here there's something missing. It is missing because the screwdriver had to come into the abutment from the side. Yeah, and therefore you have to take away this part. And on the other hand, when you have lost this part, then the bonding area is not as big as it is with a normal abutment, and this may get problems when you bond the T-base to the zirconia crown, and it may get loose after some years. So here you see a very nice case, and you will love this case, Stefan, because here it is a case with an angled screw connection, and for sure I have to splint these crowns because we have a very strong vertical bone loss, and the implant length is between 4 and 6 millimeters. And the crown implant ratio is between 1.9 to 2.5. So in this situation, the only possibility is splinting the crowns. And we go for tissue level implants. Yeah. Why? Because when you go for tissue level implants, you get a better crown implant ratio because you make the implant a little bit longer and the crown a little bit shorter. And on the second step, you take away the gap from the bone, from the tissue up to the area of in the mouth. And so here you see this situation, and you see with a angled screw connection, you can screw in this restoration. So you have a lot of mechanical stability, and you have no subgingival implant abutment gaps anymore because of the tissue level system.
So Stefan, in this case, I would have exactly done it like this, but the alternative would be a cement retained reconstruction on individual abutments, right?
Yes, and we will talk about this on the next slides.
Got it.
To bring you the disadvantage of this situation is that the internal connection is completely lost.
Yeah.
And you can see it here. It's really terrible. Yeah, you have only the screw which is looking out of the crown, and all the forces is going on these three screws. And especially in a case like this, if one of these screws get loose, especially if this screw get loose, for example, yeah, or this screw, and you have chewing force here, then you have a situation which is not stable anymore, and the patient will realize this, in my eyes, too late, yeah, because then you have a long lever on these 4 millimeter implants, and this may get problems in the end. So now I come to the cementation, and you already gave me the right words for that. What is the big advantage of cementation? You can splint these crowns without a problem. And the most important point is you need individual designed CAD/CAM abutments for that, because you need a supragingival cementation line. That is something I really want to have, so that we don't have any cements subgingival, yeah, or submucosal. And the nice thing when you go for cemented crowns is, if you have a minimal misfit of the restoration, and we have talked about this before, then the cementation gap will compensate this misfit, because there's a little bit space which can help us to take away this misfit, and so we can cement the crowns without creating tension. And this is a very important point in my eyes. And on the second point, we have the internal connection completely used in this situation. Yeah, so it has only advantages. The only disadvantage you have is that you have no predictable removability of these crowns. And that's a big disadvantage in my eyes. Yeah. So now I've shown
Stefan, you don't see any disadvantage in cement remnants?
No, I don't see it because that was the thing I want to tell you. Perhaps I have not told you in the right way. I need a individual designed CAD/CAM abutment, and you can see my laser point, and the cementation line is supragingival, and you can design this in a perfect way if you have these individual designed CAD/CAM abutments. Yeah. And then the cementation line is a little bit supragingival or epigingival, and then you have no problems with cement.
Okay, got it.
Residuals. Okay, and this is also shown in a lot of studies. You have only problems with cement if you cement subgingival, yeah, and if you
or on standard abutments.
Yeah, on standard abutments, that's clear. However, this study will also show you that it's not always possible to reduce the cementation residuals. Here in this case, it's a study which we performed in our clinic, and we have made a RCT with splinted versus non-splinted crowns on short implants, 7mm implants. Yes, and I can show you now the 3 years result. You see, we have two titanium individual designed titanium abutments, and we have single crowns or splinted crowns. Yeah, and here you see the non-splinted crowns, and here you see on the baseline that sometimes you see some cement residuals here, and which we have to take away afterwards. And here you see the splinted crowns, and here non-splinted. And we made X-rays after baseline, after 1 year, and after 3 years. And the result which we could show in the study is that the survival rate of the restorations and the implant was 100%. The technical complication, there were no difference between the groups, and splinting the crowns on short implants neither seems to affect the amount of marginal bone loss nor the peri-implant health. So we have the same number of peri-implantitis and mucositis in both groups after 3 years. So this study shows us that you can splint or you can non-splint these implants. You will get the same results in the end, even if you cement the crowns. Yeah, that is the result of the study. So Stefan, now I have shown you a lot of technical realization, and now I show you some of the complications you can get. And all the complications I show you are my complications. It's not complications of someone else, it's complications which I produced and has to look for after. One complication is, and that's very interesting, there's a study of Pietoson, it's not a study, it's a meta-analysis of Pietoson. And he showed us that the debonding of the T-base when you're looking for monolithic zirconia single crowns is 13% after 3 years. And I thought 30% after 3 years debonding of single crowns, it's so high. Mm. And then I tried to find out what is the reason for that. And it was not written in the article. So they could not find any reason what might be the reason. And even in the discussion, it was not written something about this. So in my eyes, one reason could be these short and conical titanium bases, which I showed you before. This is only a theory. Yeah? And so the solution would be to make longer and more parallel T-base. So for everybody who is listening to this Just Ask today, check with your dental technician what kind of T-base is he using, and is this T-base a good choice? Yeah, that is something you have to check with your dental technician. So in this case, you see a bridge. It was a cantilever bridge, and I show you this is when we baseline of the bridge, and this was 2 years later. So 2 years later, I lost the bonding here. We have a debonding on both abutments, and we have ceramic fractures here. So it's not clear what was first, but it's also not important. The problem is, in my eyes, short bonding areas and this conical situation. So the next time we took another titanium base, and it's a little bit better, but in my eyes, it's not really very good. It's a little bit more parallel and a little bit higher. So you have to check this. Another mechanical overload of a
Stefan, can I have one question to the prior case? It also seems to me, I'm not sure about the tie base. Is the whole internal connection here engaged, or is this also a bridge abutment, which also
It's a bridge abutment. It's always a bridge abutment. That's something I told you at the beginning. If you have a situation like this, if you have two implants and you have to place it as a bridge, then you have always these bridge abutments. Yeah?
But this could be also play a role in the debonding because there might have been more movement. Could that be a reason?
For sure, it could. It could be also a misfit, problem of misfit.
Right at the start.
Yeah, right at the start, I pushed the screw in, and I have tension on the bonding area. If it's not working perfectly on both positions.
Got it.
And that's the reason why I said it's really so technical and sensitive, this topic. So this is a very special case because it's a very good friend of mine here. And the patient is a very good friend of mine. And it's a very strong man, yeah? And he really was able, with extreme chewing forces, to change the position of the splinted implants. Here you see the splinted implants, and you see this composite splint here, and you see how the implants, the crowns are going like this, yeah? And it was so strange for me. And when I screw out the screws, then I realized that he was really able to change the screws here, yeah? And you see also the screw is not anymore straight, yeah? And he has too much forces on this screw. And the reason maybe, or in this case for sure, is that we don't have the whole internal connection. And this type of internal connection, which we have here, is a CAD/CAM designed part of this connection, which is not fitting in a perfect way. And you can see here, I can move it a little bit, yeah? And this movement allows perhaps changing the screw and working on the screw and changing the metal around the screw so that it can start working. We changed the screws, and I said, okay, it will work perhaps better with new screws. This time the screw broke completely. And it was a lot of work to get out this screw. In the end, I managed it. It was fine. But I promised him not to use these crowns anymore. And the only thing which for me is a good idea to change the system now is going for single crowns. Single crowns with an internal connection. With the internal connection of Straumann, the original internal connection. And we changed this. Here you see the splinted crowns. We changed it to unsplinted crowns on both sides. And now it is working since 3 or 4 years without problems. So I have a better mechanical stability. However, I have more load on the sinus augmentation, which is with these implants, which is used with these implants. But in this case, it worked fine now, like it is.
Stefan, there's a question from one of our listeners to this case. Why didn't you do cement retained?
It would be another very good idea to do it cement retained. It's it's an alternative. I think it's a very good alternative because then you combine splinting and splinting and the
engaging
and the internal connection which is used. That's the word. Okay. Yes, it's a very good idea to do it, but I decided in this way to do it as a single crown. Yeah.
Got it.
When the single crown will not work, I will splint it with a cementation.
Okay. Good.
Okay. Next case, and that was also a very interesting case, and it's a very actual case. Here in this situation, we have again very marked vertical bone loss, and we have a sinus augmentation, and you see that nearly all the implant is standing in the augmentation area. Yeah. And the crown implant ratio is not too bad. It's between 1.4 to 1.5. So normally, in my department, these implants should be splinted, as I showed you before, as our concept in our clinic. And we splint it for better mechanical stability and for reduced load in the augmented bone. However, this co-worker of my department, he did not splint the crowns. Yeah, it's fine. He said, okay, it's better like this, and he went this way, and it has advantages with the interconnection. We have discussed this before. However, we lost this implant 1 year later. Yeah, and now I placed a new implant at the same position, and the new concept for this situation is that we will redo also this crown, and we will splint these 2 crowns now. And this restoration is now in preparation, in progress. Okay, yeah, that's it. So now I can summarize everything, and then we can discuss it, and then we can go back to your first case. So in my eyes, or literature is telling us that splinting will reduce the masticatory forces on the implant-abutment connection and the bone. Yeah, that's for sure. However, in my eyes, splinting should be used only when biomechanically it is necessary, because splinting is very technique sensitive in my eyes. It could occur a lot of tension on the implants, on the screw, because of a little bit of misfit of the restoration. And then we have the problem that often we have the internal connection not used in these splinted restoration. And this weakens in the end the implant-abutment connection. So when splinting, please think about cementation, because cementation is a promising alternative to screw retention. Thank you, Stefan, for giving me this topic. It was a great pleasure to talk about it together with you.
Stefan, that was amazing. Great topic. I think we could talk for another 1.5 hours. We already talked half an hour in our pre-meeting about this. And Stefan, we don't need to look at my case from the beginning. You convinced me. I will not splint these crowns. I would not splint them anymore. I understood. I had a little bit the logic of a surgeon. You make one thing and you get a result. No, you make one thing and you get a result and a disadvantage with it again. So you got me. Stefan, this was amazing. Chapeau, and thanks for your material. The people, they applaud you. Stefan, let's rather go back to the questions of the listeners, because we have a lot of questions for you. I think great questions. The first question is one question which I also came to my mind, and I guess you will answer it a little different than we are used to it. What about bruxism? We sometimes say, if there's a bruxism, we splint. But today I would think, if there's bruxism, should we really splint? Because then we lose the internal connection, and this might also not be a good idea. What do you think?
Yeah, perhaps as the other listener told us, perhaps and what is also in the summary, if you have someone who is bruxing, then perhaps splinting is a good idea. So perhaps cementing, using the internal connection, and splinting together is a good solution for this patient. But the thing which is even much more important in this situation, or even important, is that you make a splint for the patient, a night guard for the patient, so that during the night all the forces is getting on the night guard and not on the teeth. Because the biggest problem with Braxas is that implants, you are not feeling the same on implants than you feel on teeth. So you feel on implants 9 times less than on teeth. And that is a big problem, especially if you have a lot of implant. Then the Braxa is working even harder on their teeth. And yeah, and therefore it's a big problem if you have a Braxa for everything. So the question is, what kind of material you are using in this situation? I would go for monolithic silicon oxide. It's the best way, I think. I would try to splint it, and as I told you, perhaps I would go for cementation in the situation. Or if I have enough bone, no splinting and using the internal connection. Yeah.
Stefan, there's a question which also would be interesting for me, but I think we discussed about it. Does it make a difference considering bone level implants, meaning quite deeply placed implant? Let's go for a quite deeply subcrestally placed implant versus a tissue level implant. I think you already alluded to that. Would you like to give your thoughts on that a little bit more?
Yeah, it's a very, very important question in my eyes. From the, excuse me, from the prosthodontic point of view, the tissue level is always more easy because you can see what you are doing. If you go on bone level, then often the implant abutment connection is so deep that you don't see anything and you don't feel it really. Is it on position? And if there's any misfit, you will not find it out. And even if you make an X-ray, you could see on an X-ray only something if you really are directly in 90 degrees on the implant abutment connection. If you're a little bit under or over 90 degrees, then you will never see a gap between the implant and the restoration. So in my eyes, the tissue level is always much more easy and much more controlled for the prosthodontic treatment. So, and that is something which is also speaking, if you're working with bone level implants, then this is something which is speaking for the multi-unit abutments, because with the multi-unit abutments, you're placing the multi-unit abutment, and then the platform you have is a tissue level platform in the end. And then you have a little bit more control for the impression and also for the restoration in the end.
On the other hand, I also see a lot of tissue level implants where you can hardly insert the screw because the implant is placed too high. So this is difficult with the tissue level implant, is the running room you have for your abutment, right? So you have to be a good surgeon because it has to be, you have to do everything in one shot, right?
No, and there's another problem with tissue level, that it's not so easy to have your emergence profile in a perfect way. Right. If the implant is too high, then you have to go out like this sometimes. So it's completely right. Tissue level is only very good in my eyes if you have enough space for the restoration. So if you have not enough space for the restoration, it's much better to go for a bone level implant.
Got it. Stefan, there are a little bit a question. Now you also get your critique, like I got them from you. So the people want to fight back you. So they ask you, why did you place this implant in the situation where you lost this implant far to the distal and you had a cantilever to the mesial? Could this also be a reason why you have lost this implant?
It was like this, that it was the only position where I could place it in a good way. It was for sure I tried to get the implant much more mesially, but we don't see now the three-dimensional situation of the implant. Yeah. There was not enough bone, and and there was another problem that the root is coming a little bit on the distal side. So there were 2 or 3 problems which are not allowing to place the implant more mesially.
Got it.
That was a problem in this special situation. Normally, it's absolutely clear that I would try to place the implant much more mesially in this situation.
There's a question on individual abutments, but I think we answered them. When I understood you right, there's no problem if you have an individual abutment and you have a supragingival retention area. There's no problem with cement. Would you allude maybe to what kind of cement you're using? You're probably not using an adhesive material, right?
No, in this, it's like I said, if I have a normal situation, that means I have titanium abutments, and then I cement. I have to make a short break because my cat is
Okay, I got it.
Is making noise at my.
Okay, I got it. I will give you the last question. I think we got that on abutments, and we have just one more last question for you, Stefan. If he ever comes back, here he is.
I'm back again.
Sorry, Stefan. There's one more last question on implant crown ratio. I mean, we discussed about this. Where do you see the risks? Is there really a risk for you for losing osseointegration? So this is a question from a listener. What is the risk if I ignore a certain implant crown ratio?
To be honest, if you see the EAO statement, then there's nearly no risk, because the statement shows you that the crown could be more than double the length of the implant. And that's a lot. That's really a lot. You have seen all my cases. there was only one case where this crown to implant ratio was higher than 2.2. So in my eyes, this crown implant ratio is something you never will go over it, so that you really have to think about splinting the crowns.
Stefan, I can pretty much stress that also from my side. I do a lot of cases in perio patients where we lost a lot of height, and I often have sort of weird implant to crown ratio, and I really never encountered a problem. But of course, I think of splinting in weakened bone areas, of course, as you said it. Stefan, that was amazing. The time flies. I learned so much. Actually, I have to change some of my lab things for tomorrow, because I already asked for splinted crowns. I will change that tomorrow. I will give my lab technician a call. Stefan, that was amazing. I really would like to do a part 2, maybe in the beginning of next year. If you want, I'm on your side. Everybody loved it. We have still some more questions there, but I think people will see you. I think they can buy your book. They will maybe come up to you on the conferences. Maybe we see you at the EAO in Monaco. With this, Stefan, I would like to thank you on behalf of the EAO for making this possible. People love it. You can read the chat later on. They say, wonderful presentation, great one. Yeah. They loved it. They also say that it's very practical. So with this, Stefan, I would like to thank you. I would like to thank all the listeners. It was an amazing evening. I personally learned a lot. I guess everyone else also learned a lot. With this, I say good night, good morning, or have a great lunch wherever you are around the world. Thanks to Professor Stefan Wolfart for his time. And with this, have a nice evening. Stefan, again, thank you, and see you around. Ciao, ciao.
Stefan, thank you very much. It was a great pleasure to be here with you. Bye.